Hello, I'm Jason Alter. I'm head of scientific affairs for Exosome Diagnostics, which is part of the larger Biotechny Corporation. Exosome is based in Waltham, Massachusetts, and we specialize in being leaders in exosome research and the utility of exosomes for clinical applications. My specific background is in prostate cancer. I've helped and contributed and participated in the development of a number of assays over the last 20 years, all focused in helping clinicians make better or more informed decisions in the area of prostate cancer. What I'd like to talk to you about today is truly exciting technology based on exosomes that are not widely known. I'd like to tell you something about exosomes, and then I'd like to tell you about how they're being used clinically in an actual assay. So there are three goals from this presentation. The first is to explain what exosomes are. Uh, for those of you who are not aware, this is a fairly new field of exciting discovery. To talk to you about what the clinical challenge is that we're applying them to, and then to show you how exosomes are providing benefits to patients and their physicians in the area of prostate cancer early detection. So let's first talk about exosomes and what are they? Well, the first thing to understand is that exosomes are very, very small. They're actually measured in nanometers, and nanometers means dwarf in Greek, and they're actually on the order of billionths of a meter. So exosomes are truly very small microvesicles that are shed from pretty much every cell that we know about. They're on the order of viruses. And this particular image is giving you an idea of scale of a typical cell, which is measured in microns, anywhere from 8 to 12 microns for a typical cell. From there, you go to platelets, then bacteria, and then you go to the level of viruses. And exosomes are so small that they're on the order of viruses. And we talk about them in the range of 30 to 100 nanometers typically. Now, like most great things in science, exosomes were originally thought to be junk. So in 1967, there was some of the original notation of microvesicles. And at the time, as research progressed, and we're talking on the order of a small number of papers per year, exosomes were thought to be junk. And it reminds me back to when we first learned about introns in DNA, and they were originally thought to be junk DNA with no real value. And over time, as you look at this timeline, exosomes were determined to be secreted from various cell types and involved in various activities, ranging from antigen presentation to ultimately where we now know that they're mostly involved is cell to cell communication. And this paper that came out in 2008 was actually quite pivotal in the area of exosome research by Skog et al., because it determined and was able to demonstrate that exosomes not only have RNA, but can use that RNA to modify the recipient cells. Dr. Skog on this paper was the founder of Exosome and is one of the world leaders. And Exosome as an entity, as a corporation, is actually doing a lot of the cutting edge research, which is typically unusual because in typical science, the academics lead first, followed by the corporate world. And here we have an organization, a commercial organization, that's actually ahead of pretty much everyone else in the development and applicability of exosomes. So in 2008, Dr. Skog founded the company that I work for, Exosome Diagnostics, and then we went on from there. In 2012, the National Institute of Health instituted a Common Fund initiative for exosome research, and the field has exploded. There are thousands of exosome papers that are published yearly. So what do we know about exosomes? Well, we know that they're released by pretty much all normal and cancerous cells. They're small vesicles, double bilayer vesicles, and they contain representation of the cells that shed them, which means they contain RNA, DNA, and protein. And we now know, as you'll see in a second, that they're a form of cell-to-cell communication. And actually, they are very stable for RNA, which is a very labile part of the cell. Exosomes protect RNA very well, and that has worked to the advantage for clinical diagnostics. So, exosomes, because they provide such protection from the elements for their contents, and in our particular use, we're primarily talking about a RNA. They're an excellent source for biomarker use. They can actually be used for RNA transcriptome profiling. And exosomes are completely separate and apart from what you may know about circulating tumor DNA or CTCs. These small vesicles, as I mentioned, are produced by all cells, and that includes eukaryotes, prokaryotes. And we know now through the thousands of papers produced every year that they play a variety of roles in normal physiology as well as different disease states. In fact, they're even being used for drug delivery. Let's talk a little bit more about how they're different from traditional cellular communication. We're all taught about in college about the different ways that cells communicate. Everyone is familiar with the basic pathways of endocrine, paracrine, neuronal, and contact versions of cell-to-cell communication. This is what is in basic textbooks. And what I used to be able to say were that exosomes will be in future textbooks and next generation textbooks for how we teach science students about a new, previously unknown method of cell-to-cell communication. I can't say that anymore because I've actually presented this through recent medical residents who've actually learned about this in medical textbooks. So exosome-mediated cell-to-cell communication is now actually being taught as a new method of cell communication in textbooks that we use in medical school. So exosomes are actual mediators of various biological processes, and I've talked about that in a general way. And now let me talk about it in a specific way. I'm going to place these all up on the screen at the same time. They're known to be involved in everything from memory and learning to cancer suppression. They're involved in virus cloaking. In other words, it's been demonstrated that as a number of viruses can actually be packaged into an exosome and therefore evade UV inactivation, which is of great concern, obviously, for processes that use that methodology to try to provide a virus-free or environment. They're involved in various parasitical infections. I'm showing you schistosomes, which are worms that reside in the blood system for up to 30 years, as well as ticks. They're now known to carry flaviviruses when ticks bite humans. They modify the tumor microenvironment. And then, of course, the one I save for last is the space, the astronaut, because we're actually doing research and published with NASA. We have a long ongoing relationship with NASA, looking at physiologic changes in astronauts spending long periods of time aboard the International Space Station using exosomes to do the actual research. So exosomes, when you look at the literature, are involved in pretty much any biologic process that you can imagine, and they're being more and more is being learned about them literally every day. So what we're doing now at the moment is understanding the bare tip of the iceberg. Let me talk about some of the clinical and research applications as being done that we're doing. Well, once you release exosomes, the first thing to know is that exosomes are found in every fluid, every normal bodily fluid, whether it's saliva, semen, urine, blood, plasma, exosomes are secreted into all of these fluid secretions, and that makes them exceptionally useful for liquid-based biopsy approaches. So once you have a biofluid, the key to being successful for using exosomes for clinical applications is being able to customize isolation method that is based on the fluid that you're using and the application that you want to use the exosomes for. But ultimately, once you're successfully isolating exosomes for particular research utility, our goal is to be able to do biomarker pathway analysis of what's going on in the body in both normal physiologic as well as cancer processes. In fact, a lot of the work that we're doing in-house is ranging from mutation analysis and various splice fusions to methylation, full transcriptome analysis. We can do full transcriptome analysis on exosomes collected in small amount of urine. It's not even blood, but it's urine, so it's a non-invasive way of collecting biological samples. We can do protein and fat analysis. It's an amazing amount of data that rivals what you can get from tissue analysis, but do it in either an invasive or a non-invasive way, depending on the fluid that you select. And in particular, exosomes have a lot of power for diagnostics, actual clinical diagnostics. And that's because they can be used in a multiple different types of ways. They can be used early in the disease process to try to detect which patients are succumbing to a disease earlier than might be seen with a traditional tissue-based biopsy. They can be used for longitudinal tracking during the course of a disease. They provide real-time biologic snapshots of what's going on in the patient's biology and the potential response to treatments as we're treating the patient. As I mentioned earlier with urine, they can be minimally or non-invasive at all because these exosomes are present in pretty much every bodily fluid. And they overcome tissue heterogeneity concerns. In cancer, one of the things that we're concerned about is the difference between tumors and within tumors. They overcome that because we're collecting exosomes that are secreted by a range of the tumors that are present. And in prostate cancer, which I'm going to talk about in just a second, tumor heterogeneity is a very big concern. And then finally, exosomes have a real big advantage over traditional methods of looking at in biofluids, such as circulating tumor cells or cell-free DNA, because they provide tremendous amplification of tissue. Exosomes carry the markers of interest, the biomarkers of interest, to their destination before they're released. That provides amplification within normal physiology, but it also allows us to collect and have the advantage of tremendous signal to noise as we collect exosomes and look for biomarkers of interest. So let's talk about the clinical challenge in prostate cancer. In prostate cancer, specifically focused on early, prior to any actual prostate cancer diagnosis, about which men can safely defer a biopsy. And what that means is when you go in for a biopsy or when you go in for a physical and you receive some sort of concerning risk assessment, in other words, you have an elevated PSA or you have a digital rectal exam where the doctor tries to feel if there's anything abnormal going on in the prostate. Those patients then have to, with their physicians, make decisions on having a prostate biopsy. And it's not a straightforward decision because most of those men do not need a biopsy. The ones that do often don't receive one. So how do you determine which patients really need a biopsy and should have one and which can safely wait to have one? Specifically, we're going to talk about where that works. Within the actual process, which is building on the screen right now, Typically, patients, when they visit their primary physicians, will have their annual physicals, and then based, as I mentioned a second ago, about whether they have elevated PSA or a positive digital rectal exam called the DRE, they'll be asked to go see their urologist. The urologist will repeat the PSA and the digital rectal exam and then discuss with the patient, based on the findings, whether they should go for a biopsy, which is typically in the United States around a 12 needle core biopsy, which not every patient, as I mentioned, need. But based on that biopsy, the tissue is then fixed and sent to a pathologist. Based on that, the pathologist will look and see if they find any prostate cancer, assign a risk level to that prostate cancer, because there's both low risk prostate cancer, which currently is just being watched by doctors, and there's higher grade, more concerning prostate cancer, and those patients are typically sent for treatment. And if a patient doesn't find anything on their initial biopsy, they often go back at a subsequent point in the future for another biopsy called a repeat biopsy. Sometimes they go back for more than one. So this biopsy decision is important because within the elevated PSA, there's an area known as the gray zone, which is 2 to 10 nanograms per mil. Once again, 2 to 10, we're talking about a billionth of a gram per mil, 2 to 10 billionths of a gram per mil. And the reason it's so confusing in this area to know which patients truly might have a concerning prostate cancer or any prostate cancer is because there are other reasons, non-specific reasons, that can cause PSA to be elevated less than 10 nanograms per mil. Part of that has to do with physical activity, and part of that has to do with other conditions such as benign prostatic hyperplasia, which can also cause elevated PSA. So how do you determine which patients go forward, and why is that important? It's important because you don't want to unnecessarily expose people to prostate biopsies if you don't have to, but at the same time, you want to tee the right patients up to go. On the left-hand side of the scale, you can see the various complications associated with biopsy that range from pain, which is expected, to, unfortunately, infections, which really about 1 to 4% based on the literature of patients have infections that are concerning and send them to the hospital. And you need to remember that these patients are prophylactically treated with antibiotics. And so there is always a concern about antibiotic-resistant bacterial infections here. But at the same time, on the other side of the scale, we know that since PSA guidelines changed in 2013, without going into the details, we do see an increase in the rise of distant metastasis in prostate cancer. And therefore, we want to send the right people for biopsy, and not everyone, and we want to be able to defer for the right people as well. So how do you do that? Well, that's where we start to talk about how exosomes can be used and are being used in a clinical assay. So there's a lot of data, but in the interest of time, I want to show you just one study from the Journal of the American Medical Association that covers one specific assay. There is only one assay that's being currently clinically used in clinical diagnostics. It's this particular assay. This study was done in a large prospective blinded clinical trial for men 50 years or older with PSA in that gray zone of 2 to 10 nanograms per mil. And this particular assay is able to discriminate which patients are likely to find high-grade cancer, defined as a Gleason score of 7 or higher, from low-grade disease, which is a Gleason score of 6, and benign tissue. And this particular test, if you look at the bar chart, shows, and this is what you're looking at, is area under the curve, which is how most diagnostic assays, prognostic assays, are measured. It's a balance of sensitivity and specificity, and it's a probability scale. If you look at this, you can see that PSA has, which is traditionally the biomarker of choice, PSA has an area under the curve of 0.55, which is the equivalent of tossing a coin. When you add clinical features into the PCP-TRC, which is a prostate cancer calculator, an algorithm that combines clinical features and PSA, you can see that it does better. Standard of care was an in-house standard of care calculator combining clinical features and PSA. It's essentially the same as the published calculators. And when you get to the exosome-based test, which is the epi bar column, you'll see the significant increase in area under the curve. And finally, when you add standard of care features, which on their own are quite poor, to the exosome-based assay, there's very little movement in performance as measured by area under the curve. And therefore, what that shows is that the biomarker itself is collecting pretty much all of the diagnostic information that's available and stands on its own. And as a result of this and other studies, this particular assay was launched into the marketplace to help prostate cancer or patients going through an early detection for prostate cancer process, and is used in the field quite widely. In fact, subsequent data showed that if you look at the top chart, that in this homogeneous group of patients 2 to 10 nanograms per mil, there was an association, an increase in the scores of this exosome-based biomarker assay. As you go from the left to the right, you see that the scores go up, and the scores go up in association with the detection of high-grade prostate cancer. So in other words, the higher the score, the higher the likelihood, up until about a max of 50-60% of finding high-grade cancer. And there is a maximum there because prostate cancer biopsy by itself, although it is the gold standard, actually does miss about 50% of cancers. If you look at the chart on the bottom, what you would find is that PSA within the 2 to 10 nanogram per mil range, regardless of how you bucket it out, actually doesn't have any ability to discriminate which patients have any cancer, let alone prostate cancer. So how do you use this clinically? Well, there's right now for early detection, there's a discussion about how biomarkers and multiparametric MRI can be put together to provide benefit to patients. In fact, it was fairly recent editorial here at the end of 2022 that actually talks about potential scenarios for putting biomarkers and MRI together. And the short answer is we're in the infancy of how we do this. Nobody understands completely what particular process is best, but we do know that biomarkers and MRI both have their own strengths and limitations. And when you look at MRI, which is accepted widely in guidelines for clinical use for early detection, what you would find is that it is a risk assessment method similar to biomarkers that provides a probability of finding concerning tumors. This particular chart shows in red the percentage of high-grade tumors in a risk assessment method known as PIRAD scoring in prostate cancer. So these grades 3 through 5 are considered from intermediate to high risk cancer by multiparametric MRI. And what you find is at the low end, there's only a small percentage of high-grade prostate cancer that increases, but is still not 100%, even when you get to the highest grade. And so from a risk assessment point of view, MRI has its own strengths and weaknesses for teeing up patients for early detection for high-grade prostate cancer. So how do you combine biomarkers with multiparametric MRI to provide a benefit? And we're in the process as a community of doing that right now. One of the papers I want to show you in the interest of time that's looked at this is this paper out of UCSF. So let me skip that. And this paper by Dilakaye et al. Explored how to potentially combine MRI and biomarkers together. It is an observational study. It is not a prospective trial, which is needed. But what they did was they looked at some of the commercially available biomarkers and then suggested potential ways that they might work together. And in this study, everyone had a biopsy. They had no previous prostate cancer diagnosis. None of these people were diagnosed with prostate cancer. Their PSAs were all below 20 nanograms per mil, and they must have had one of the commercial biomarker results. And if I were to skip to the chase, I would show you this result. This is the exosome-based assay that I've been mentioning. And in purple, what you're seeing is the number of MRIs, of biopsies that could be avoided, and the missed percentage of prostate cancer that you would find. And what they found ultimately is this particular algorithm called algorithm 4. And in this algorithm, they put the exosome-based biomarker first, and then based on the results of the exosome-based results, decided whether those patients went for biopsy and MRI. And what they found was that they were able to avoid 43% of biopsies that they didn't believe were necessary, and only miss less than 5% of Gleason 7 or higher high-grade disease. And they were able to avoid almost 40% of MRIs. Now, although this is an observational trial and it doesn't have the power of a prospective trial, studies like this are indicating that MRI and biomarkers, and in this particular case, an exosome-based biomarker, can be used together to provide better patient care. And this study concluded the way that I think that we need to discuss it, which is that prospective validation studies are being developed and are needed to actually determine the best way to put biomarkers and MRI together to help patients in prostate cancer, but I would argue in multiple types of cancer. But in prostate cancer, where I focus, that's where we're going. So I hope that what you've come away with from this presentation is the fact that you understand what exosomes are at least a high level. And if you didn't know about them, you're interested in learning more about them. That these exosomes are not only have been developed for use in the clinic, but actually there is one clinical assay in the world that I'm aware of that is currently being used in the field of early detection for prostate cancer. And in that specific clinical niche, it's addressing PSA issues and earlier requests from the field and from various agencies for biomarkers that improve the specificity of detection. And it aids patients and their physicians from making shared decisions that improve patient compliance and quality of care. And unfortunately, due to time considerations, I don't have time to go over the level 1 study that actually reviews some of that. And then finally, key that this exosomes can, on their own, without any inclusion of clinical features, provide an independent perspective on risk assessment, in this particular case for prostate cancer, and then ultimately for other disease states as well. Thank you for attending, and if you have any questions, please put them in the Q&A box, and I will answer them directly when they're provided to me. I appreciate your time in listening to this, and I hope it was useful.